السلام عليكم ورحمة الله وبركاته. أهلا بكم أيها الزملاء الأفاضل والأساتذة الأعزاء في لقاء علمي جديد من لقاءات وحدة جراحة الجهاز الهضمي والكبد التخصصية بمستشفى العبور بكفر الشيخ. النهارده بنتابع لقاءاتنا على والكولوريكتال ويبينارز، ويسعدنا أن يكون معنا الأستاذ الدكتور ماجد عاشور بسيوني، أستاذ جراحة الشرج والقولون بالمملكة المتحدة البريطانية، وأحد الخبراء المميزين في مجال الكولوريكتال كانسر. Today this is the second part of the management of colorectal cancer. وزي ما هستاذن حضراتكم ان احنا نراجع مؤشر الصوت ونقفله والمؤشر الفيديو. حضراتكم هنكتب اسئلتنا اول باول ان شاء الله، وان شاء الله بعد انتهاء المحاضره هنزحها على الشانل بتاعت الوحده على اليوتيوب. إن شاء الله نسأل الله أن يرزقنا النفع ويجعلنا باب للعلم ينتفع به إن شاء الله. ونسيب حضراتكم الاستمتاع بعلم وخبرة أستاذنا الدكتور ماجد عاشور بسيوني. فاتفضل حضرتك ماجد.
إن شاء الله. Shall we start?
إن شاء الله هنكمل مع حضراتكم المانجمنت اوف كوليكتال كانسر مع بروفيسور ماجد بسيوني. اعتقد دكتور ماجد يعني اهتمامه كبير بالكوليكتال كانسر سبيشال ان ايجيبت. ده كان ورا سلسله المحاضرات، وان شاء الله نستفيد من علمه وخبرته ان شاء الله، وزي ما حضراتكم ان شاء الله اللي هتنزل على الشانل بتاعت الوحده ان شاء الله. اتفضل استاذنا الفاضل دكتور ماجد.
إن شاء الله. Thank you very much. I just wonder if I can record this or not. I don't. Oh, hang on. Stop recording. Pause record. So you are recording it, are you?
Okay, I'm already recording this.
All right. So because I can't.
Okay.
Assalamu alaikum wa rahmatullah. I know that there are 11 people here. So what we'll do tonight, inshallah, is to carry on where we stopped last time, about 2 or 3 weeks ago. As you probably are aware, going back. Well, I've left Sheffield University now. I'm privileged to be part of Anterior University as well as a visiting professor, but I'm now a professor in 2 universities in the UK, Lancashire and the Highlands. So I'm moving on very quickly, and soon I would also take another leading role in the Middle East, which hopefully I will be closer to Egypt so I can help a lot of people. Just a note to people who are present, and I will repeat that in the end, and hopefully many other people will join. I've started a program of helping doctors, especially with colorectal cancer. I know that there are not too many people who spend more than 75% of their time dealing with only colorectal cancer or colorectal disease in general. And I would like to increase this base of hope that you will get together with the Society of Colorectal Disease in Egypt to strengthen your ability to create guidelines, to work together, to advise each other. For that, inshallah, in the end, I will show you a link that from next week, you will be able to log in and book a slot, which we'll call it a class. And during that class, if you have a difficult case you want to discuss, I'm very happy to discuss it with you, share with you all the investigation possible. Make sure that you have, it's like Zoom here, you can share the screen so we can look together at patient. I'm even happy to discuss the patient with you in your clinic while the patient is present. I know it is very arduous. It's probably not all patients in Egypt will accept that, but my aim is not patients, to be honest. My aim are colleagues, my aim are students, my aim are trainees, my aim is to help sharing the experience with difficult cases in colorectal cancer or benign colorectal disease. So if you are interested, I will pass this link to Dr. Saadi, and inshallah, I'm sure that he will help spreading the word that I'm happy to help. Maybe twice a week, I will open the classes and it's obviously free for all of you, for all colleagues who have difficult cases to discuss. So we'll go back to the subject of today. What we did last time, the people who did not attend, we discussed the basis of colorectal physiology and anatomy, the epidemiology of colorectal disease, cancer, and the pathology in details. And we presented how the patient present and how we diagnose them. There are things that I'm still seeing cases and examples coming from the Middle East and unfortunately from Egypt, and I have to be honest, patients who are diagnosed in a very unorthodox way, which can lead to trouble, not only not following the guidelines, but the patient safety is at risk. I'll give you one example of a patient I have seen yesterday and another patient I've seen three days ago. The patient yesterday had abdominal symptoms, which are very typical of cecal cancer, anemia for a long time, not diagnosed, and being given treatments for IBS and blah, blah, blah. And he had ultrasound. And the abdominal ultrasound showed abdominal mass in the right iliac fossa. And the radiologist correctly said, this is a cecal tumor. And how the cecal tumor was diagnosed and confirmed? By taking transcutaneous ultrasound biopsy. This patient had, in my opinion, stage 2 cancer, probably in T2, T3 cancer, N0, M0. Just by the virtue of taking transcutaneous biopsy to prove what the diagnosis is, this patient now is terminally ill with cancer spreading everywhere. This is not the way we diagnose cancer in the colon. This is not the way even the undergraduate books are written. So please be careful of what you do to the patient and be very diligent in following guidelines. And if you have a problem, ask a colleague, ask someone who's more experienced. Another patient who was suspected to have cancer in the morning and went to have an operation without diagnosis in the evening. Unfortunately, the patient was dying 3 days later when they contacted me because no staging was done. And the patient didn't need an operation because it will not change their life. It will not cure him. It will not save them. And the operation was totally unnecessary. And I have to say, unfortunately, the team who treated him killed him. So let's be careful with what we do with colorectal cancer because it can be cured and it can be of good outcome to the patient quality of life. And then we had a break, which is not a coffee break. We had a break for a couple of weeks. And now today we'll talk about staging, treatment, and outcome of treatment. I don't give statistics. I'm not talking about research. I'm not talking about graphs. And I'm talking of practical experience of 35 years treating colorectal cancer. So please ask questions if you want. We will have time in the end, but even if you want to interrupt me, raise your hand and I will answer any question I have. I'll give you examples of what happens in real life in MDTs, how we discuss them, how the patient is managed according to the evidence available to us. And I will add few things to the slides I will show you now because there are things have changed only in the last year, only in the last 6 months. There are things have changed, especially with rectal cancer. You will find that I will focus on rectal cancer in detail because this is the bugbear of coloproctology. And it's the bugbear of patient care because it needs a lot of evidence behind it and a lot of care and specialization, which is something that's lacking in the Middle East, I'm afraid. Okay, we talked about the anatomy, the physiology, and the epidemiology of colorectal cancer, and the risk factors, and we talked about hereditary disease and inflammatory disease, and also the various syndromes that are associated with colorectal cancer. We gave some examples. We discussed the factors with less clear effect and other risk factors like the racial and ethnic background, type 2 diabetes and its effect, although it's not very clear. We talked about the screening of asymptomatic patients, which is something I'm dreaming of. I am absolutely dreaming that I would not die before I see that happening, like what is happening now with the breast cancer, the prostate in Egypt, and hepatitis and all that stuff. I hope young surgeons like audience, and I'm sure there are lots of senior surgeons too, will be very keen on taking the initiative in Egypt, encouraging the president, because things have to go through him. That is right, there's nothing wrong with that. But someone close to him, please tell him colorectal cancer kills a lot of people in Egypt, and screening can save lives, and it will be very useful. We talked about the clinical presentation, that many patients are asymptomatic, hence the screening program is important. We talked about how emergency presentation is very common in Egypt, unfortunately. How when we examine the patients, we have to be very careful of not neglecting digital rectal examination and luminal examination, either by bronchoscopy or sigmoidoscopy, which is the initial investigation in my mind, like having a stethoscope, through which, if you have flexible sigmoidoscopy available, clear hand with that preparation, just 2 enemas and wait for an hour, you can detect 75% of tumors. We talked about diagnosis, that it is not by blood test, it's not by tumor markers, it's not, they are not sensitive, they are not used for screening, they are not productive, they are waste of time, they can give you false sense of security, they can actually ruin patients' life because you tell them and the lab tell them you haven't got a tumor. Please don't use them for diagnosis. We know that colonoscopy and biopsy is the gold standard. Nothing else replaces this. Whatever anybody says, luminal examination is important. You will see the tumor like that or early, and do not forget that low rectal cancer and inner canal need J maneuver to see them. They do not appear as you go in, they appear if you reverse the scope inside the rectal ampulla. Do not forget that the modern colonoscopy machines, they have very specific and very good way of cellular examination. As you can see here, there are pig pattern changes with high dysplasia. In this case is not really cancer, but we can talk about this in another time. We talked about the genetic testing and how important they are these days to plan the treatment, and especially chemotherapy, especially the modern way of wait and watch, and the modern way also, and the discovery that in BRAF and MSI genetics, that most of them are not responsive to chemotherapy, and chemotherapy may increase the chance of distant metastasis rather than immunotherapy as it should be, or targeted therapy in some cases. We talked about the barium enema and its limitations, talked about what it means to have CT colonography. If you ask for CT colonography, expect this type of pictures. Do not expect a normal CT scan with good reports. I have seen the colon. This is not CT colonography. CT colonography is a specialized program that's expensive, and it is not necessarily a different machine. It is a software inside most of the machines with 128 slices. And it is something that it needs at least 2 hours to interpret, 2 hours for the machine to produce these images. And many radiologists will not do that because it's a waste of time, because they want the patient to be diagnosed in 5 minutes. But if you want CT colonography instead of colonoscopy, ask for the proper CT colonography, and hopefully radiologists and radiology centers will help you obtaining them. This is how it looks, and this is very characteristic of cancer. Obviously, it doesn't mean that you operate in patients, because the pictures like this, it also means that you know where to take the biopsy from. So we do not use CT scan for diagnosis. We do not use MRI. We 100% do not use PET scan for diagnosis. We do not use ultrasound of any modality for diagnosis. They are for staging. And tumor markers like CA25 and alpha-fetoprotein and HCG are not specific for colorectal cancer. If you are suspecting colorectal cancer, this is waste of money. And because, unfortunately, the care in Egypt relies heavily on the private sector, you exhaust the patients in investigation that they don't need. And when it comes to treatment, they don't have money to pay for the operation. And they argue and they negotiate to the detrimental effect of their outcome. So if we look after them from the beginning, they will listen to us in the end. And let us be honest, we are all doctors here. When you ask for investigation that's not required, patients think that we are ripping them off and they don't listen to you, whatever you say. So let's be selective with work ethics. I'm not accusing anybody, but I've seen practice all over the world, and I know what can be waste of resources and what can be useful. Now we'll talk about staging, okay? And I don't know how many of you are studying, how many of you are doing their training or studying for various degrees and fellowships and all that stuff. But I hope the message will be clear of what I'm saying and how we can talk about staging and apply it to practice. It's not just talk about it, okay? The staging is always preoperative. Staging is never operative. Nobody can say, we'll do laparotomy to find out what's wrong. This is extremely old, outdated, dangerous practice. You must take your time to diagnose and stage preoperatively. Absolutely necessary and true for rectal cancer or rectosigmoid cancer, because the treatment options are many and the patient outcome relies heavily on the accurate preoperative stage. I will talk about that in details in a moment. What's the clinical stage, okay? Clinical stage is extremely important because the ground, the base for staging is, as you see, the American system is slightly different to TNME. And unfortunately, the standardization around the world is not very clear. However, if you are being examined for fellowship or you're studying for fellowship in Britain, do not use the HGCC. We do not use it here. We do not say stage 1 or 3 or 2A or 2B or something like that. It's not something that we really worry about. Do not waste your time if you are sitting the exam. If you are working in the Middle East with oncologists, like the Gulf state, if you are working in many Egyptian institutes, I know that many of our wonderful professors use the American system, yes, in real life. But the slide is busy and we can talk about it to the judgment day or until the cows come home, as we see in England. And this is theory, so you can read it whenever you like. Hopefully the recording will be available and you can go through this slide yourself. But what I'm trying to say is that you need to really identify with T1 tumor and T4. T1 tumor is only submucosal invasion. What happens if there is a tumor not invading the submucosa? We call it TIS. What happened to the tumor that we think it is there, but we cannot see it? It's called TX. And then the T2 and T3 are very wide range, but the key here is that muscularis propria and the muscularis propria into subserosa, okay? And we'll show you the slide in a moment that will explain T4 directly with other organs. Let's talk about rectal cancer again. What are the other organs that can be affected? Do not forget pelvic muscles, levator, intercoccygeal muscle, sacrococcygeal muscle, transversus urethri. All these muscles are adjacent organs. They are not part of the rectum. So if they are invaded, it's T4. Do not forget that, okay? And if we talk about N is N1 or N0 or N1 or N2. In the past, we used to say N1 is up to, it is paracolic lymph node, and N2 is the apical lymph node. In a preoperative staging, it is wrong to say that. What we now say, it is 3 lymph nodes, unless 1, 2, 3, it is N1. More than 3 lymph nodes we can see in a CT scan of good quality or MRI is N2. It's not the apical lymph node anymore. So if you come to the exam, especially in Edinburgh where I examine, be aware of this answer, okay? N1 or N2 are very different. M is easily explained. It's either there is distant metastasis, which is M1, or there isn't, it's M0, okay? What it means in graphic details is, and why we really insist on knowing the TNM or the AGCC staging, because survival is very different between stages. If it's T1 or stage 1, stage 1 includes T1 and T2, by the way. If it is stage 1T, stage 1 means there are no lymph nodes or metastases, and the tumor invades only the muscularis mucosa, not muscularis propria. Okay, the survival is 95% with treatment, and treatment is usually surgery, nothing else. No chemotherapy or radiotherapy in this stage, stage 1. If it's T2, which means went into the muscularis propria, but not through it, the survival can be up to 90%. Usually the colon presents 23% of them in stage 1, and rectal is 34%. Stage 2, which is T3 tumor, without lymph node or distant metastasis, means through the muscularis propria into the submucous or even into the fat surrounding, if there is fat. Remind yourself all the time, the rectum does have fat, the sigmoid does have fat, but there are parts of the rectum that does not have fat, and this is very important, which is the very low rectum, below the mesorectum. And the survival in this case is 70 to 85%, but it will be multimodal. It could be surgical, could be surgical and radiotherapy for in the case of rectal, neoadjuvant mean preoperative, or surgical and adjuvant, which is postoperative radiotherapy and chemotherapy for colon. And here I will have to stop. There is no evidence to support preoperative chemotherapy in colon cancer. There is no evidence. It's experimental. There are about 6 or 7 international trials going ahead at the moment. And the trial that's successful is the trial that's with no surgery, If you want to give patients chemotherapy for colon cancer, you will do that not to operate on them later, just to leave them alone and observe. And they are very selective in these cases. Stage 3, which means lymph nodes, whatever N1 or N2, 1 to 3 lymph nodes, as you can see here, 50, 70%. When there are more than 4 or more lymph nodes involved, the survival really drops down, okay? Presentation is becoming less and less, and most of the cases are really distributed equally, but stage 2 is the most common. So how do we stage them? First and foremost, especially in rectal cancer, is your finger. And in colon cancer is your hand. It's called Mason clinical stage, and it's especially for rectal cancer, but can be applied to colonic cancer too. Freely mobile tumor over muscles or in the peritoneum. It correlates well with clinical stage 1 up to 70%. in correlation with histological findings. 2, mobile but not separate from rectal muscle, we mean by PR examination, and correlates with up to 75%. So your finger is sensitive, could be up to 90% if you feel the rectal tumor is fixed to the muscle or fixed to the rectal wall. And these are 2 different terms. Fixed to the rectal wall, you mean you cannot move it in the pelvis at all. But fixed to the muscle, you can find little movement, but with the muscles, not separate from it. Okay? So, MRI, and I will talk about rectal cancer as we said. Let's agree from the beginning. Staging of colon cancer is very straightforward and is evidence-based. It's formed of chest, abdomen, and pelvis CT scan. In this day and age, there is no role for abdominal ultrasound. There is very little role for chest X-ray. So what is the staging imaging for colon cancer after diagnosis? It's chest, abdomen, and pelvis CT scan. What about rectal cancer? Rectal cancer is chest, abdomen, and pelvis, not only abdomen. That's why you cannot use it in the first stage of diagnosis, because if you find a tumor in the CT scan abdomen, you will fill the X-ray, you will miss the X-ray chest, and you will have to repeat it again. So leave the CT scan to after the diagnosis, which is used in the way chest, abdomen, and pelvis, not only one of them, okay? Plus MRI. And this is the very important part of staging that I will talk about today. The MRI, to obtain good reports, it's up to you what you put in the form. We talked about clinical staging, Mason clinical staging. Teach yourself how to do it. Teach yourself to give this information to the radiologist so they can give you good report. Not only what is written in the report, is the protocol of how to do the MRI. You need to learn it yourself. So when you ask the radiologist, you know what to ask them for, and you probably guide them. Say, I want to see the MRI in that way. The MRI must cover the rectum, mesorectum, and the anal sphincter, and there are 2 ways where the coil position doesn't really matter. If you want to use transrectal or transabdominal or an external coil or internal coil, that's what it has to include, the rectum, mesorectum, and anal sphincters. There are many artifacts that you need to learn, and how it is the interleaving slides and how resolution phase. And we agreed in the colorectal community that an MRI of more than 1 millimeter in thickness is not useful because of the interleaving slices. The interleaving slices causes a lot of artifacts in interpretation, and it will cause a lot of defect. Why 1 millimeter? I will go back to Phil Quirk's and what we found for years since the late 80s until now, that the CRM, circumferential structure margin, is one of the most important factors in determining the outcome of rectal surgery and rectal cancer. If that circumferential margin is threatened by less than 1 millimeter, you will need to give neoadjuvant preoperative radiochemotherapy or short course radiotherapy, depends on where you work and who you listen to. If the MRI preoperatively is 5 millimeter thick, means that if there is any slice between the 5 millimeters you sliced in the pictures with a threatened margin, you might do a wrong operation. You may disservice the patient by giving them the wrong treatment. So 1 millimeter slice is what you need. Many machines can be adjusted with expensive software to give you this, not higher resolution or 1.5 or 3. Or in Britain, for example, we moved from 1.5 or 0.5 probably about 25, 30 years ago. Now we use 7 megahertz MRIs. So don't accept low quality. Know where to send your patients if they have the facility to do the proper high resolution MRI. You will see some pictures later. Okay, you must be assured that the technicians know about the motion artifacts and what to do and can give the Buscopan. Okay, what you need to understand, and you study and talk to your radiologists about the frequency, encoding, directions, and how to select the criteria during the protocol, not just an MRI who someone had it for his head or bone for, or muscles or pelvis for pelvic pain, and then you put the patient in. It's totally different program. It's totally different protocol. You need to work with the radiologist to achieve that. And this is the type of picture you need to get. The resolution in this screen is not great, but I'm yet to see in many countries a picture like this. And I'm telling you, this is not great. In the MRI machine, this is 3 Telsa. And in the MRI machine, you see it's a lot better than what you see now. But what you need to look at, not only the bladder and the muscles of the bladder and the prostate and the plane between the prostate and the seminal vesicles, how clear they are. But what is very important to the surgeon is this. This plane is what we call the circumferential resection margin, which is the mesorectal fascia. This envelope of fat contains blood vessels and lymph nodes. You can't see lymph nodes here because that's normal. And that is what you see, for example, where the circumferential resection margin is, and the tumor is here, and I've marked it here. This is the rectal muscle wall, and you can immediately see the thickness of the rectal muscularis propria here is that much, and here is very thin, meaning that the tumor has gone through the muscularis propria, because it should be the same thickness all the way around. So it has gone through, but it didn't go through the muscle into the fat. So that is T3, okay? And this is how the diagrammatic presentation of the same picture, you need to put it in mind and read the images, not only the report sent to you. What do you expect for the MRI report? In rectal cancer, again, I'm focusing on the rectal cancer. You need the MRI report to tell you the distance of the lower border of the tumor from the anal verge. You need it to tell you the height of the tumor, how long it is, obviously the position, and as you saw in the picture before, the T stage and N stage too. Okay, I prefer this view, which I call it the surgeon view. It is the coronal view, because I'm able to go back and forward in the abdominal cavity and the abdominal wall, and I'm able to look at it from the surgeon point of view. You are operating on the patient like this. And as I said before, the report is great. Talking to your radiologist and your colleague is greater, but the greatest is that you look at it yourself. You learn how to read it yourself and give the radiologist your feedback, especially after operations. Transabdominal ultrasound does not have a role these days. This is a very old way of staging the liver, which we used to have. I lived that time, and we used the liver ultrasound and chest x-ray. Now nobody does that. So in exam, do not mention the liver ultrasound, except if you say this is an old way of doing it. Some books still mention it, but not in practice. It doesn't really work in practice. And what you see is a lesion like this that's hypodense with some peripheral density around it, and you have to be careful with which stage you're doing it. Chest x-ray, tumor has to be that big to see it on a chest x-ray. It is not something we rely on staging. And so again, this picture is shown just to be obsolete. Barium minimum is not for staging. It can be used for diagnosis if the resources are not available for luminal examination. But abdomen and pelvis and chest X-ray are very important staging to detect distant metastases as well as T stage of the colonic cancer. And it was good. And if you have a really good spiral CT and fantastically interesting radiologist in GI and rectal cancer, you may be able to have a near correct CT scan stage. I'm terribly sorry, just give me 1 second.
Okay, Dr. Majid.
Sorry, Habibi, I'm here. I'm terribly sorry.
Okay.
Okay, and then the chest X-ray, as you said. Now, how do you order a CT scan for colorectal cancer staging? What we use, and I'm open to discussion, I want to be convinced of anything else. We use IV contrasts, triphasic, with no oral or rectal contrast. We do not give patients contrast. And if we do, it's only if we suspect concomitant lesion in the small bowel. And if we do, we give what we call negative contrast, either water, mannitol, and that is it. No gastrographin, no paste, no enema, nothing. Bowel preparation is optional. It depends on the radiology and the center you're sending it to. There is something called fecal tagging. If we want to do it, it is a very advanced technology that to differentiate between tag and between stool and polyp in the colon, especially in CT colonography. But for staging, we do not give any other contrast other than IV contrast. If you give a positive contrast, like I see in Egypt all the time, barium is given, gastrographin is given, you will hide mucosal abnormality. And it will be very difficult to detect muscle wall or a bowel wall abnormality. Why triphasic? Triphasic is most useful in the liver, most useful in the lungs, but it's also useful in capillary stage in the bowel wall, and that is the basis of enterocolysis, CT or MRI enterocolysis. But the messages I want to give, a practical message is, giving contrast in the GI tract, positive contrast, will hide GIST, will hide mucosal change in inflammatory bowel disease, will hide wall thickness change in colorectal cancer, and please ask your radiologist and the leaders of radiology in Egypt to change that practice. It's not useful. Now, during the discussion, I would love to hear from you and tell me I'm wrong, because we can discuss that until, again, the cows come home. Okay? Ultrasound. And that is something interesting, exciting, and only today I've seen a case of a 52-year-old woman who had a polyp removed from her rectum in 2010, had a flexible sigmoidoscopy in 2013, had another colonoscopy in 2015, all that because she has bleeding per rectum, and had another colonoscopy in August this year. So 3 years and 2 years again and 5 years, and still nobody could, with colonoscopy, detect appropriately the tumor that she has had for at least 3 years. And it's a flat tumor, it's difficult to see. And when the MRI was done, the MRI, I wish I had the pictures. The patient actually was discussed today, so I'm sorry I didn't have pictures of that. But that happens, just to give you a flavor of what actually happens in practice. and the MRI was recorded no tumor. The patient, the hair surgeon took her theater about 2 weeks ago and examined her under anesthetic, and he can feel the tumor. So a clinician can feel the tumor. MRI says there is no tumor, and the MDT discussion, the tumor board, what you call it in Egypt, couldn't decide what to do with that. What evidence shall we say that she has a tumor? It's only the patient's finger, the doctor's finger. And during the meeting, I came in and I did a transrectal ultrasound, and the tumor was there, very clear as a T2 tumor, T1, T2 tumor. So transrectal ultrasound is something that needs to be encouraged to be used. It's very useful to use for large polyps, sessile polyps, but it's very important, A, not to take biopsy before the transrectal ultrasound because it ruins the picture. Not to do any trial dissection. And the only thing that he can do as a test during colonic examination is lifting. Try to lift the tumor, the polyp, if it appears polyp. If it does not lift completely all around and under the base, please don't do anything at all, not even biopsy. And send your patient to someone who knows how to use the ultrasound and he can read it properly. We'll show you some pictures now, and you'll be amazed how rigid. I have been using the rigid ultrasound, which is a BK machine, for the last 25 years. There are US machines are not really designed for rectal cancer. They can be useful for colonic cancer, but they are not widely used for that. They are mostly used for upper GI cancers and pancreatic. But for colon, it's not widely used, but it's used widely, the high resolution. When I mean high resolution is 20 megahertz and above. The machine I use, upgraded it from 12 megahertz to now 20 megahertz rigid. Doesn't look like that. It looks something else. I will show you. It looks like this. And as you can see here, if you go back to this picture, we look at 5 layers of the rectal wall, okay? This is an interface between the probe and the mucosa. It's not the mucosa. And the mucosa is black, and then the submucosa is gray, and then the muscularis propria is gray-grained, and then there is perirectal fat, which is just outside. And that's how it's used. It's 360 probe. So it looks all around at the same time, and it's high resolution. This is 16 megahertz. And you can see here, for example, that there is muscularis propria invasion here and where the tumor is. It's compressed, so you can't really see the exovitic part of it. And the staging is fantastic. And I have papers, but what is important in the 3D ultrasound, that there is another software you can update the machine and you get a 3D cube, what we call it. And this cube, I don't have a video, unfortunately, to present, but I will, hopefully, because I'm not at home at the moment. With this cube, you can turn it every way you want. You can dissect it. You can remove the muscle from the tumor and see what's left in the muscle. You can actually do a virtual operation on this cube, and you can very precisely understand and know where the tumor is from all aspects. It's literally, you can, as if you remove the rectum from the pelvis and looked at it in the light. It is just something that, unfortunately, it's not used. This is one of my patients who had, there is no name, so I don't know. And that's, for example, there's only mucosal fold here. It is not really a tumor, but there's a breach of tumor here of the muscularis propria. It's not that difficult to interpret, really, because this is muscularis propria, which is the black ring, as it was. And that, I'm terribly sorry, this is the muscularis propria, is this white ring, gray, not black. And you can see the tumor is pushing into it, okay? So there is a little breach, and this is about 2 millimeters. If you miss that in MRI, you will not really see, you will not appreciate this is actually T2. You will think it's T1 or probably benign tumor. It can be used in many, many ways, and how it is used and how the T3 tumor is not difficult to identify. And the pictures are far better than anything you can use. But it is limited to tumors of 20 centimeter maximum height. I remember this slide when we first put it together and put the course together in 2003, 17 years ago. The limit of examination of rigid sigmoidoscopy, and in many books it says 6 centimeter. Believe me, with the new technology and the training, you can go up to 20 centimeter in length. But the 6 centimeter in the books, you have to be very careful. That's 20 centimeter from the anal verge, but the tumor itself must not be longer than 6 centimeter to be examined in one go. Otherwise, you have to repeat the test many times. Because the crystal that reads, it moves up and down in variable speed, and you can speed it up or not, to get the cube only for 6 centimeters. So you can't really examine a tumor longer than 6 centimeters. But you can examine tumors up to 20 centimeters from the anal verge. Obviously, it's not suitable for tight tumors, and it's operator dependent, but I can prove you with research I have published many years ago, and my trainees talked about. It's superb on T1 and T2 tumors, a lot better than MRI. The sensitivity of transrectal ultrasound is 98% in T1 and T2 tumors, or the interface between the two, while the MRI is only 71%. So what do you choose to be accurate staging in early cancer? There is no doubt it's the transrectal ultrasound. When it comes to T3 and T4, you probably don't need transrectal ultrasound, but the MRI is better in this stage. Lymph nodes, with the new machines, you can detect lymph nodes better with the transrectal ultrasound, but they are not widely used. And in 5 years' time, we'll be able to talk about it. PET scan, do we use it for staging? No, absolutely not. Is it used for staging in Egypt? Yes, in every case. Sometimes for diagnosis, we use CT PET scan. I don't understand it. I don't know why people are using PET scan for staging preoperatively. And all the scientific community and the colorectal community in Britain do what I don't, the word is despise the PET scan, because it's waste of resource, absolute waste of resource to do CT for PET scan for staging. I hope the staging is clear, and I'm sorry I've taken so long, but I think it's very important to go through that, because it's far more important than treatment options. I will go through this quickly, and then we'll have a few minutes for discussion, and I can see people are bored and left. The treatment of rectal cancer, because treatment of colon cancer is surgery until contraindicated. Nothing else. No chemotherapy, no radiotherapy, either surgery, and the surgery varies, but we will talk about this, and I will discuss with Dr. Ahmed Saadi that we need to talk about the complete mesocolic excision, which is different than the traditional right hemicolectomy or left hemicolectomy as we do it. It's very important, and the outcome is a lot better, but more difficult to do. But we'll talk about rectal cancer quickly. Surgery is the mainstay of treatment, and it must be borne in mind at the beginning of staging. Radiotherapy, either long course, short course, or surface, which is intracavitary radiotherapy. Chemotherapy, either preoperative or postoperative. This is the rectal anatomy, as we can see, and very quickly we can say if it is in the low sigmoid or rectal sigmoid is high anterior resection, low anterior resection if the tumor is in the upper third, ultra low if it is in the middle third, abdominal perineal if it involves the anal canal. That's as simple as possible, but there are many, many ways of lower rectal cancer staging that will help the decision making if you want to do organ preservation or sphincter preservation. And this classification, for example, is very important. It's very new. It's been around only for 9 years or so, and you need to understand it very well from the books. If the tumor is about 2 millimeters away from the levator muscles, you do a TME type resection and you leave the internal and external sphincter. If the tumor is less than 1 millimeter from the levator, or there are lymph nodes or doubtful shadows here, you will do what we call transsphincteric dissection, and you cut part of the internal sphincter. And if it is definite invasion of the anal canal here, you will, which we call intraanal tumor, infiltrating the internal sphincter, we need either to do total intersphenic dissection, which can be done, and nowadays we do it with TATME, or if type 4 means that the tumor infiltrating the external sphincter, not only the internal, that is AP resection. Okay, healed, as we all know, introduced the TME, which is based around the circumferential section margin and the identification of the neurovascular bundle, which is just lateral to the seminal vesicles in men. And the anterior section must be done by sharp dissection to include all the mesorectal excision. And that's a very old picture of mine, of probably in late 90s, because I stopped doing open surgery for a very, very long time. And the principles of the intersphincteric dissection is very important. You have to do a bottom-up approach, not coming from below from the abdomen, but you go from the anal canal up. But if you how to join the bowel together, you better use a colonic pouch if you can, because we found that 8% of straight anastomosis will have permanent stoma as it fails to heal due to various reasons. Now with the use of ICG, indigo common green scopes, which are very expensive, but they are really picking up pace in the practice of colorectology and rectal cancer, you can reduce this 8% to about 3%. So you can still do straight pouch, but you have to have special machines to make sure the blood supply is all right. Early function in the pouch is better than straight, and the pouch must be of 6 centimeters in length. Okay, colorectal cancer, as we explained, the operation is done on the screen before you do it in the patient. That's why studying the images yourself is very important. That's why you need to understand if the tumor is that advanced and after radiotherapy is still present in that extent. You can see here the external sphincter is involved, and you need to decide which level you are going to do. This is the levator muscles. Are you going to stick to it? You probably have threatened margin after the operation or involved margin. Okay, staging is very important, and there are 2 types of AP resection. I'm talking now about tumors invading the anal canal and especially the external sphincter or the levators. And either traditional APR, abdominal perineal excision of rectum, or extended, which is something that you need to learn about, even especially if you come into an exam. Okay, you need a specimen looks like this, smooth, with no breach of the mesentery, and with a good tie. And what is extremely important, that the mesentery here looks like an L shape, all right? This is something technically very important to make sure. I've seen so many specimens, they go like this, and then they go out to the tie, the high tie, and then go back again. And people say, I've taken all the mesentery. No, you haven't, because you should not have a tail going to the mesentery. These specimens are horrendous. How to join the bowel again, it's usually by staples, but you can do it with hand suture as well, as the diagram below here. In 20 years, we found that APR and CRM involvement is up to 13%, okay, 2000 European data. The classic study showed 21% of traditional APR have involvement of the circumferential margin. That was repeated in the Dutch trial, 1,746 patients, 30%, the Norwegian trial, which included 6,000 patients, by the way, 13%. So it's a lot of recurrence. So what do we do about it? Is instead of going very close to the bowel like this, as we do, we come outside, or at least halfway into the levator muscles. So we extend the operation a little bit, okay? But even with the definition, we have studied that already, and the tumor regression. But what we need to study very well is the relation between the levators, the tumor, and we measure that very clearly. And if the slices are 5 millimeters, it's absolutely useless. So 1 millimeter is very important. And then we'll decide on what operation, depending on the levator. Here you can see it's involved. If you do a traditional type of TME, you will come this way, you will break through the tumor, and you will go out happy because the patient went home next day, went home in a week, and they are eating and drinking. But they will come back next year with another tumor. And unfortunately, they will not come back to you, and they will not send your relatives to you because you didn't do the operation properly. So the operation is very different. It's called ELAP, extended. So if the tumor, this is the definition of the traditional or standard APR. However, the specimen comes like this with a waist, and if the tumor is here, the circumferential margin will be involved. So what we do is the extended or extralevator abdominal perineal excision, which do not go through the rectum or close to the rectum, but we come outside at the levator muscles and excise a very wider part of the pelvis. And the specimen will look like that with no waist, and the tumor is far away from the circumferential margin, and the recurrence rate is a lot better. There are problems with the APR in general with perforation, but with ELAP, the problems are a lot. The intraoperative perforation or positive circumferential resection margin is far, far less with the extended. And that's how Phil Quirk taught us how to stage after the operation. Nothing new, because it was actually described in 1918. So what do we do? If we suspect a lower rectal cancer, if it's too painful, we examine under anesthetic, and examine for mobility and distance from the anal verge and the dentate line, and then colonoscopy and biopsy. Nothing else. We do not do ultrasound. We don't do anything at all. If it is squamous carcinoma, we'll treat by surgery straight away. Adenocarcinoma, we'll do staging. If it's adenoma, we can remove it by many techniques like TAMIS and TA, TME, and TEO, or TEMS and LAW, many others, which are many invasive. Systemic changes will take place. If it's disseminated disease, we're going only palliative treatment. Do not operate in people with disseminated disease. They do not benefit from anything. If it's resectable metastasis, you can study the local extent, and you can decide to look the metastasis with you. If there is no metastasis, so we'll have local extent study. If it is staged and discussed in the MDT, sorry, this slide is very busy, but I think I have dealt it. We are selective in Britain. We do not give everyone radiotherapy, and we can give short course of radiotherapy or short course radiotherapy or chemoradiotherapy, which is a long course. It depends on the MDT discussion. There's no fast, and the evidence is not clear which is better. And now there is something called the Rapido style, which is a trial just finished, hasn't published yet, in Sweden, that we can, with rectal cancer, we can wait and because Habagama, who died recently, said that we can watch patients for longer than we do. But we have to give chemotherapy, not only watch them. Okay, I'm terribly sorry it is too long, but I think it's extremely important to go through this in detail. And I hope I have cleared some of the points. and I hope we can answer some questions. You're more than welcome to ask what you want to ask. Okay, we can talk about the, I'm sorry, let's just close this. We can talk about the follow-up after treatment, cancer MDT, who are they? But thank you for tonight, and please ask your questions. And then I will give you the link. You can from next week, inshallah, I mean from next not Saturday, tomorrow, next Saturday, you can book what we call class, not consultation, it's class, and we can discuss cases together if you want. Right, any questions?
صراحة actually we are very enjoying well by this such very illustrative important lecture دكتور ماجد بصراحة يعني الواحد لسيته من قريته بيرلز يعني من خبرة حضرتك يعني واعتقد ان احنا في احتياج كتير لخبرة حضرتك والمحاضرات كتيرة ولو طمعنا ان احنا لو هنبدأ مثلا بعد اذن حضرتك يعني في اي وقت يناسب سعادتك the surgical view of MRI in colorectal cancer ده مبدئيا يعني ده بعد اذن حضرتك يعني على بال ما
انت عايز تسال على السيرجيكال فيو. Yes, well, the surgical view is many, but you need to learn how to look. I will give you some pictures so you can discuss it. Okay, surgical view is the coronal view. ما فيش كتاب بيقول اسمه surgical view. That's my term. لو عايزين تزودوه على الكتب زودوه بس
لا ده محتاجين لا احنا محتاجين ان خبره حضرتك في محاضره منتصره على الجزئيه دي.
اوكي من عينيا الاثنين.
تكس عاليه جدا.
يا ريت ندعي some radiologists كمان علشان نقنعهم ما يدونوش كونتراست. وانا هجمع لكم اكبر عدد ممكن من الام ار اي. اتفضل.
تمام اتفضل يا دكتور محمد. دكتور محمد اله اتفضل.
السلام عليكم.
وعليكم السلام. شرفني بصورتك يا دكتور محمد.
الله يصلح. شكرا دكتور ماجد على المحاضره الفيري نايس ليكشر. حضرتك الله يخليك. بس لو قلنا كرايتيريا اوف انريسكتابيليتي في الكولون كانسر.
اوكي. زمان وانا صغير كنا بنقول unresectability كان في حاجه اسمها trial resection. There is no room for trial resection these days. There is no room. The preoperative staging deleted the trial resection. So what is the unresectability according to the preoperative staging? Are you talking about rectal cancer or colon cancer as well?
Colon cancer.
Colon cancer. Unresectability of colon cancer is A, invading adjacent structures that cannot be resected, like IVC, like spine or rectal or posterior abdominal wall muscles. Anterior abdominal wall muscles are resectable, but posterior abdominal muscles not. Invasion of duodenum, except if you are really brave and you want to do Whipple procedure with rectal cancer, which I have seen disasters from, but some people say they do it. So invasion of vital structures that cannot be removed, mainly major blood vessels. But I will add to this something very important. Widely disseminated disease is unresectable, not because it cannot be removed, because it's wrong to do any surgery for these patients. So you need to expand your definition of unresectability. It's not technique. I am old surgeon. Young surgeons, they think if they can do it technically, so it is doable. I have to do it. Old surgeons like myself say, no, I am not going to do it because it's not going to benefit the patient. I will also call that unresectable, means it's forbidden, ممنوع resection. مش إنها مش ممكن، إنما ممنوع. وده فايدة ال MDT. MDT بتاعي أنا عشان معلش أنا يعني هزود شوية في الشرح عشان تعرف يعني إيه resectability by MDT. MDT في physiotherapist، في specialist nurses، في psychologist، cancer psychologist مخصوص للكانسر بس، في gastroenterologist، في radiologist، في histopathologist، في clinical radiologists، في medical radiologists and they are different. لأن زمان ما فيش حد دلوقتي من الانكولوجيست بيدوا كيموثيرابي وفي نفس الوقت بيدوا راديوثيرابي، دول منفصلين عن بعض في بريطانيا. وفي medical students، وعشان تعرف بقى في كمان ايه، في patient liaison، في عيانين بيقعدوا كل اسبوع معانا واحنا بنناقش الحالات علشان يدوا وجهة نظر المريض في كل حالة. انا نفسي اشوف الكلام ده بيحصل في مصر، انما this is what happens here. فلما بنعرض الصورة وانا اقول انا ممكن اشيل التيومر دي، العيان ممكن يقول لي هتشيلها ليه؟ العيان ده ما بيمشيش من البيت، ما بيطلعش بره، قلبه مش عارف فيه بلا بلا بلا، فيبقى المريض ده unresectable. حاجة تانية مؤخرا بس من 12 سنة اللي فاتوا ابتدينا نبص لها كويس جدا، patients fitness for operation، مش مجرد ان احنا شايفينه قاعد على الكرسي وكويس. في حاجة مهمة جدا دلوقتي بنعمل لها تيست اسمه CPEX testing، cardiopulmonary exercise test، دي computerized، بيدينا الفيجرز، بيدينا رقم اسمه الانيروبيك ثريشولد. الانيروبيك ثريشولد ده ارقام، معلش مش بنشرحها في وقت تاني. لو الانيروبيك ثريشولد اقل من 8 بالسيبكس تيستينج، حتى لو العيان شكله فت لاقصى درجه ما بنعملوش عمليه، يبقى التيومر دي unresectable حتى لو كانت ممكن تتشال، لان العيان mortality بتاعه هتبقى very high. من 8 ل 11 بنعمل لهم rehabilitation لمدة 4 أسابيع قبل العملية. مفيش حد بيعمل عملية في نفس الليلة ولا بكرة. فوق 11 بنحجز لهم عملية في خلال أسبوع أو 2. فالريسكتابيليتي دلوقتي definition في العالم مختلفة خالص عن إمكانية إن احنا نشيل التيومر ولا لا، ومفيش حاجة اسمها تراي ريسكشن. أرجو إن أنا أكون واضح.
شكرا دكتور. يعني حضرتك الفيجن للرايت كدني او الليفت كدني، يعني ممكن نشيل الكدني مع
ممكن نشيل الكدني، لا لو كدني فانكشن ممكن، وممكن نشيل partial nephrectomy كمان. يس
partial nephrectomy.
يس.
طيب ممكن سؤال تاني ولا في حد هيسأل حاجة تانية؟ دكتور أحمد؟
اتفضل يا دكتور محمد، اتفضل.
another question، لو الكيس presented by دكتور أحمد، السلام عليكم. لو الكيس presented by perforation
yes.
at the site of the tumor, not distal to the tumor أو proximal يعني.
You need the operation if you need to save the patient. Obviously, if they have quality of life, it's an emergency operation, but never, ever, ever try to join the bowel together. You must do a stoma. It is usually perforated tumor means a T4 already by definition, and they will need chemotherapy post-operatively.
Thank you so much.
Now. دكتور جابر،
اي اسئله ثانيه؟ اي اسئله ثانيه؟ طيب دكتور ماجد، بصراحه مستمتعين جدا باللقاء وبالكلام يعني، وخبره حضرتك الجميله دي.
ثانك يو حبيبي.
شاكرين لحضرتك جدا بصراحه.
العفو.
الله عنا كل خير.
خليني هعمل شير بس في حاجه واحده بعد اذنك. شير سكرين.
اتفضل حضرتك.
شير سكرين المره دي وايت بورد. Where is the whiteboard? It's interesting. Can't do whiteboard? It's interesting. I don't know how to can write. Okay, I will tell you something. Let's go back here and let's get escape. Write something. Pen, maybe. Right. I will say it, but please. That's not the way. Screen vital. And show. Let's see. Yes. Okay. I will add a picture. Oh, hello. Hello. Can you see the screen ولا أنا مش عامل sharing؟ مش عامل sharing.
لا screen بقى لا دلوقتي.
Clear. Okay. This is the site Prof. Bassuini, that's how it's spelled, setmore.com. Okay. This is what will be, inshallah, from the 7th of September. Yeah, 7th of September, inshallah, it will be available for doctors from Egypt only, nowhere else, for difficult case discussion. And you will have to choose something called class. Okay, not consultation, class. And what it is, you will book the slots, and then we will have a separate video conference, which is the telemedicine. It's medically and medico-legally correct. So we can share patient information أو حتى لو البيشنت موجود عندك. كل اللي هتحتاجه إن أنت يكون عندك كمبيوتر فيه كاميرا بس. هذه كل الحكاية يعني. فمش محتاج بروجرام ولا حاجة خالص.
حاجة تبعت لنا شير دلوقتي ولا؟
أهو أنت مش شايفه؟
حاجة لا ما نزلش لسه.
مش موجود على السكرين؟
لا ما فيش سكرين ظاهرة دلوقتي.
طيب حالا دلوقتي share screen. Here it is. اوكي. هو ده السايت.
تمام.
من يوم 7 سبتمبر، اوكي، مش من دلوقتي.
تمام ان شاء الله.
اوكي. ممكن احطها في الشات كمان لو حد Prof. Bassuini.setmore.com. اوكي.
اوكي دكتور ماجد، ربنا يبارك حضرتك ويجزيك عنا خير الجزاء، وببلغ شكر الساده الزملاء الفاضل الحاضرين لحضرتك جدا، ونسال الله ان يجعله في ميزان حسناتك. جزاك الله خير وربنا يبارك فيك.
دعواتكم وحافظوا على نفسكم من الكورونا بليز. يعني الواحد بيسمعه بيزعل جدا، بيزعل. فان شاء الله خير. اوكي، يلا ربنا يحميكم جميعا. مع السلامه. مع السلامه. مع السلامه.
شكرا جزيلا. عليكم السلام. السلام عليكم جميعا. عليكم السلام ورحمه الله. الله يسلمك.
مع السلامه.